Hey everyone, Jeff Horowitz with Dentist in the Know. Today is Wednesday, which means it's time for Hump Day Happy Hour. And I'm excited about that because I really need some time with my besties. As you know, Dentist in the Know is your backstage pass to current trends, politics, and education in the dental world. We are live and we're over a little cocktail, much needed cocktail tonight. I am with my two best friends in the entire world in this venture of Dentists in the Know. They are Dr. Chad Duplantis and Dr. Jennifer Bell. Together, we make it our job to bring you everything that's happening in dentistry in the most unpretentious and the most fun way. Tonight's show is sponsored by Align iTero. We have an incredible guest, Dr. Mike DiTolla, who I'm sure all of you know. And so without further ado, I don't want to waste any more time. I just want to say hi to my two besties and welcome to all of you out there. And so good to see everyone again.
Welcome
good to see
back.
you, brother.
It's good to have the trio.
Yeah, the band is back together again.
That's right.
Right.
They were probably starting to worry we were Beatles, turning into the Beatles or something.
It would seem that way, but it seems like we all had the last month or two. It just seems like we've all been in a lot of different directions. So it really is good to all be back together again.
Absolutely. So glad. I am dying to know, Jeff, top 3 new things that you learned in the world of sleep dentistry. I'm really dying. And if you say nothing, then I'm going to be depressed.
Oh, no. You know, that's not the case. So number 1 is, first of all of you know not to ever put a wallet on a bar or take your wallet out of your pocket and put it in a public place. You just don't do it. I never did it. I don't think, JB, you would ever take your wallet out of your pocketbook and set it on the bar. Chad, I bet you've never pulled your wallet out of your back pocket, set it on the bar, right? Now, but I will say, I bet one of the two of you at least have set your phone down somewhere.
Yeah, sure. Many times.
Yeah. So, a couple of years ago, I decided as a consolidation thing and to make sure that I didn't lose anything anymore, that I would combine my phone and wallet. So now I would just have all my credit cards with my phone. And now I didn't have to worry about leaving something anywhere.
What could go wrong?
What could possibly go wrong? All that time, I never did lose my phone or lose my wallet until this weekend. Unfortunately, what really didn't ring through my brain was that when you set your phone down on the bar, it is still your wallet because it has credit cards in it. Just because it's not a physical wallet doesn't mean I didn't set my wallet on the bar.
Yep.
And lo and behold, my phone and credit cards were swiped. So lesson number 1 learned at the Academy, the American Academy of Dental Sleep Medicine, was if you are combining your phone and your wallet, please don't set it on a bar. And for that matter, don't even set your phone on a bar in Las Vegas or anywhere for that matter, because they are very easily swiped. And we actually have the footage of the person reaching over and doing the quick swipe. And I'm sure that was not their first rodeo. So
I told you.
Anyway, lesson number 1.
I told you when you sent that. I knew someone that happened to a year ago as well.
What'd you say?
I said, I told you I had a friend that very same thing happened. He was at gaming, slot machines or something, and he set a phone with wallet attached, and they spent quite a few dollars using his stuff.
Oh yeah. I've got a lot of charges out there, but also got to spend some quality time at the Clark County Metropolitan Police Station, which a lot of nice folks. Yeah, a lot of nice folks down there. Yeah.
I hear it's the top 5 tourist attractions of Vegas.
Yeah. That's one spot
Okay.
I'd probably leave off the list. But
Number 2.
Chad, number 2, and this was really key. That oral appliances are now surpassing the efficacy of CPAP with regard to reducing 24-hour blood pressure. Huge.
Whoa.
So now we have the data
Whoa.
comparing people in oral appliances versus people in CPAP across all severity levels. And now we've learned that we are surpassing the improvement in 24-hour blood pressure with oral appliances than we are with CPAP. So
Hey,
that
Jeff,
was huge.
is that the same across mild, moderate, and severe? Or
Yes, it was across all severity levels, randomized.
Interesting.
So yeah, absolutely unbelievable. The other thing is we're going to see a whole new breed of wearables come out, way beyond where we are. Home monitoring is going to be taken to the next level. So for titration, we are now going to have some inexpensive ways to follow up our patients and titrate them from home, where it goes to their phone and to the cloud at the same time. So we're not having to spend as many visits with patients. So a lot of cool stuff
That's
happening.
really awesome.
As always with this meeting, I wish they would have talked more about other therapies other than oral appliances. But this group in particular has always been very appliance centric. So, but still a great meeting until Saturday when I couldn't attend anymore because I didn't have a phone or a wallet or time because I had to go to the police station.
Right. So it's really interesting that you bring up the titratables, because I had a patient in today who I was talking to. I'd already talked to him once about sleep, super high palatal vault, very constricted. And he has had issues for a long time. And he said, I went, got the sleep study. You told me to get it done. I did. And I do have sleep apnea. And the sleep doctor said, don't worry about it. I said, what? And he said, yeah, he said, don't worry about it. And I was like, I need more context. There has to be more to this particular story. Anyway, why I bring that up, because the interesting piece of that was he's tracking himself on his Apple Watch as well. So it'll be interesting to see how some of these additional monitoring systems, et cetera, become normal. Like you don't even have to get a physician order to start testing your own sleep accurately at home. I think that's where we'll be, and because it's honestly a bit of a backlog.
Yeah, and there's still a wide spread between what is approved publicly and what is approved as a medical device. But yeah,
but if you could pre-screen at home effectively with the just like that new device that you can use, you stick your 2 fingers on it and it does an EKG reading. Like if you could do some of that pre-screen at home to be able to take that paperwork to your physician to say, I think there's something going on, you'd really be truly testing people that likely have
absolutely earlier diagnosis for sure.
Right, absolutely.
So, yeah.
Very cool.
Yes, thank you. Chad, what about you? What are you up to?
I think this conversation might be putting me to sleep.
Yeah, he's just doing lots of shitty dentistry out in Keller, Texas. What's changed?
Lots of shitty dentistry. Yeah, no, everything's good. It's great to see you all. Jeff, we missed you. I got to tell you, last week
I missed
we had an episode on dentistry and the overall health of the body, the oral, dental, mental, body health connection. We really needed a segment on sleep, and us 2 laggards weren't really able to provide it. However, if you all will go to TikTok, which I don't talk. I have my wife's account on my phone, and she gets mad when I like things. that she didn't tell me to like. I didn't know it was her account that was on my phone. But anyways, I think we were up to like 120,000 views on this dang TikTok where I mentioned Dr. Peppermouth. So
We may be
I
getting
like
sued.
Dr. Pepper as much as the next guy, but geez, oh Pete, it was crazy this past week what happened.
I loved
So,
reading some of the comments because some of them were like, I'm watching this segment while drinking my Dr. Pepper, or like, don't tell me that that's my absolute favorite. And then a few were also notable mentions that Mountain Dew has to be somewhere in that mix. And I think,
oh,
for
no
sure.
doubt. In South Carolina, it's the top of the list.
Yeah.
Yeah, I
Do the
told
do.
my favorite comment was I've been sober from Dr. Pepper for 6 months. I
That's fun.
was like, oh my
It was
gosh,
fun.
that's fantastic. So anyhow,
Yeah,
we
he's
missed you last
TikTok
week, Jeff.
famous
We
now.
really needed you. Yeah.
Thanks.
Yeah.
I've been missing you guys, and just already feeling better now that I've seen you.
We
Well,
knew we'd be the medicine.
good.
Well, you want some news? Because that will depress you again. I'm really good at that.
all right,
Yeah.
let's do it.
Way to
I'm
freak
some
really,
news.
up.
I'm really good at it.
Yeah. All right, go ahead and do it.
Or is the news just really good at depressing us? I don't know. You have to. You can't blame the messenger.
Exactly.
No, you can't shoot the messenger. All right.
That's right.
Do the
All right, you
news.
ready?
I'm ready.
Okay. I'm going to start with the most important story because it needs a call to action to all of my fellow business owners. This one is incredibly important. As you know, coming for vote very soon is the big, beautiful bill. And of course, this is a financial bill. It is meant to manage some tax cuts, put us back to the 2017 tax cuts, which I'm kind of a fan of. I think that could be very helpful. But there's one little hidden gem in this bill that dentists in particular, and dentists who own their practices most particularly, should be concerned about. Let's dig a little deeper into the details. So it's a few years ago that they put into place the SALT Act, and that was a cap on how much you could run your state and local taxes through your practice. It capped at $10,000. Well, for small businesses, that was a big deal. So a workaround that many states put into place was the PTET. And what that means is the pass-through entity tax, I think. Hold on. Let me make sure I've said it correctly. Anyway, the PTET meant that you could, as an entity, pay your state and local taxes at the entity level instead of paying it as an individual taxpayer. Well, what did that mean? You were no longer subject to the cap. That was a big deal because that meant that you could then write off or use that as a business expense, your state and local taxes. There's a little interesting caveat in this big, beautiful bill, and it is to restrict the ability for small service industries to be able to use this pass-through workaround for the SALT. And SALT would come back. So we would then go back to SALT cap, which would be 10 grand for state and local taxes. Those of you in New York, California, in particular, and any of the New England states, better be paying very close attention because you are the ones most subject to the most damage from a SALT cap. If it caps at 10,000 and your state taxes and your local taxes exceed that, you can only write off up to 10,000. The rest is still profit on your practice, and you will pay federal income tax on that income. That sucks. So please, please, please reach out to your House of Representative members, whoever you can get their contact, to let them know how you feel about this particular little nuance for service-related sole proprietorships and LLCs, partner-based, and this newly minted workaround to put the SALT cap back in because they don't like it. They don't like that the PTET restricted or allowed you the ability to start working around the SALT cap. They want to reinstate that. That is a no-go for service-related small businesses. I cannot stress that enough. The ADA and the AGD both have resources. If you don't know who your House of Representatives member is, first off, hate to say it, shame on you. But Be that as it may, this is your opportunity to learn, find out who they are, and go ahead and express your opinion about this particular bill. This is a call to action of great urgency because this will be going up for vote with the House of Representatives within the next day or two. I cannot stress it enough. Reach out to your House member. Okay, now that I've depressed you thoroughly with that information, here are a few other little tidbits for us to stew on for the evening. Iowa has just passed a bill that will allow DAs to work in practices without being registered. So in Iowa, all DAs must register with the state board in order to be able to practice in any practice in the state. Interestingly, a lot of the states around them didn't have that requirement. So Iowa saw the issue, has also, as many of us do, a serious workforce related issue going on, trying to get DAs and dental hygienists into their practice. So they've modified the rule to allow DAs to work with their dentists under a training program without registering with the state. A few nuances with the law. So if you're in Iowa, you should definitely look into that to make sure you're operating within that for radiography and coronal polishing. But expanded function does qualify for these non-registered dental assistants. This is an attempt, again, to help get more workforce movement and to get more people involved in the state of Iowa. This was an interesting study that came out of JAMA, the Journal of the American Dental Association. It talked about the alpha-gal syndrome, and this is a hypersensitivity that develops from a specific tick bite. It's called the Lone Star tick, so maybe Chad can tell us a little bit more about this particular tick. But there are quite a few individuals in the US that do have this disease. The interesting thing about alpha-gal syndrome is that they are highly sensitive to red meat and some medical and dental products, which can result in a variety of symptoms from skin reactions all the way to anaphylaxis. This is new on the radar for most dentists. Even the CDC hasn't really been tracking this very well. So we really don't know how many individuals in the US currently suffer from AGS, but it is incredibly impactful for how we treat those patients in our practice. And the interesting thing is, for a lot of them, it takes a very long time to receive that diagnosis. I have a couple of patients in my practice that have AGS, and it took a long time to get to that particular diagnosis. So you could have patients in your practice today that have hypersensitivities to some of the same things we just discussed, but haven't made the connection yet or had the appropriate diagnosis. We're going to need to learn a lot more about these sensitivities and about how these patients interact with a lot of the dental products on the market today to hopefully be able to continue to provide them safe and effective dental care while still using dental products and preventative techniques that we have come to trust. In particular, two things that have definitely been noted so far are fluoride gels and bone grafts. So we'll continue to stay on top of that to get you more information. My last story of the evening is really a PSA for all our fellow patients out there. Yet another story, another week of dentists practicing illegal dentistry in another state. This particular dynamic trio was practicing dentistry illegally and also participating in human trafficking. Now, we know they are innocent until proven guilty, but it is quite a heavy laundry list of accusations that have been given to them. Now, my PSA is to patients. You do know that you can go to the state dental board registry. It's all online. And you can look up your dentist to make sure they have a license in good standing in that state. And if there's any concern whatsoever that that might be an issue, I implore you, go to your state dental board website, type in the last name of the individual you intend to see, and search for their credentials to make sure that they are licensed in the state in which you would wish to proceed with the care. And with that, that's the news. Chad's broken.
Okay. I might be a little bit broken, but hey, damn it. This stupid camera. Okay, there we go. Hey, sorry, Jeff. I didn't bring you up because I got really excited when you talked about alpha-gal syndrome.
You must have 1,000 patients with it.
No, I have one. He was in the office today. So this was the topic of our morning huddle this morning because we had to he brings his own toothpaste with him to use as prophy paste because we can't use prophy paste. And so, you know, the whole morning staff meeting was kind of blown when we started talking about this one patient, because I just thought to myself, how horrible is it to live a life without meat? I mean, this guy's like a rancher.
Yeah.
I mean, how horrible is it to live a life without meat? But anyhow, I mean, and I know there's a lot of vegetarians and a lot of vegans out there, and I don't mean any I don't mean
you like to eat red meat. It's okay.
But I do like meat. I'm sorry, I like meat. But the interesting thing is that we were talking about this. I'd never heard about it. And then you start talking about Texas, and of course it piques my interest. I mean, I was asleep during the rest of the news. You start talking about Texas, and I'm like, holy crap. And then literally it was just today we had this. So I implore you, I beg you to please pull that segment out for a reel that I can share it with my team, because
on it,
like literally we really, even though we're in Texas, we don't know anything about this. Now, interesting fact about tick bites, my wife's mother, and that's how this patient got it, was from a tick bite. And I'm assuming that, I think that you were talking about that as well. Right? Yeah. Okay, so my wife's mother had a brown deer tick bite years ago, had Lyme's disease. My wife has Lyme's disease. All of it's passed on to our kids. So there's a lot of interesting things about Lyme's disease that go on within our family. Lyme's disease is very, very interesting, and I'm very well versed in that. Have a lot of patients who have been affected by it who are really from the Northeast. It's not something that we get in Texas, but we have a lot of patients that have come down from New York, Connecticut, Vermont, wherever, and they have Lyme's disease. And so I'm very familiar in how to handle that, but this is new to me. So very interesting. And I played golf not too long ago in a town called The Colony, and I came home and there was a tick on me. And so now I'm freaked out about Lyme's disease, about alpha-gal,
you better check.
All this shit. I'm like, crap. So thank you for sharing that story. And I cannot wait to share that with my team, because I think this brings up such an important point. The morning huddle. What is it for? You know, it's not to sit there and complain about who's on your schedule that day, or to gossip about what's going on in the office. It's to talk about important stuff like this. And I'm so proud of my team for bringing this up. We discussed it this morning, and then you brought it up tonight. And it just, there are a lot of things that we can hit on from this. So great job, JB. And the other stories, they sucked. They just sucked. Not because it was bad news. It's just because it was depressing news.
Welcome to my world.
Y'all got to talk in the beginning. I get to talk now, damn it. Can I introduce our guest?
Please.
Yeah, we introduce our guest.
Yeah, I'm going to introduce our guest. I can't do two things at once. So, Jeff, as I start talking, you want to bring him up?
I think I can handle that.
So if anybody has heard about, or if anybody's ever drank a red wine that might be of the Zinfandel variety, you might know that Lodi, California, is actually the wine grape capital of the world, and nearly 40% of California's premium wine grapes are grown in this region. Zinfandel is their mainly known production. However, nowadays they produce something else, something that's finer than a wine. They produce a dentist, and not just any dentist, the frickin' Mike DiTolla. This guy was in practice for 15 years before he became the director of clinical education for Glidewell Labs for the next 15 years. He led the clinical team that developed and brought Bruxer solid zirconia to the market. Very, very hard to believe how long zirconia has been on the market, but it's been on the market about as long as the iPhone. That's also hard to believe. In 2011, he received the Most Effective Dentist Educator Award in a nationwide survey of dentists. He's recently received the Gordon J. Christensen Award for Distinguished Speaking from the Chicago Dental Society. His online educational videos have over 16 million views on YouTube. He maintains a private practice focused on clear aligners, veneers, obstructive sleep apnea, and Zinfandel wines in Lodi, California. But more importantly, he's I consider a good friend. He's apparently a prolific bass fisherman. He might become professional in the next few years on catching bass on the lakes in California. He's a comedian. He's an incredible human being. And Mike, it's an honor to have you on the show.
Chad, thank you. That's one of the kindest introductions I've ever received. You pronounce Lodi correctly. Most people say Lodi like it rhymes with Jody, but you actually pronounced Lodi correctly. And a lot of my patients own vineyards and grow grapes. And the ones who grow grapes all sell to Gallo. Gallo like needs more and more grapes. But it's really interesting. The wine business is suffering a lot out here. And when you drive into town, when you drive into Lodi, it's just vineyards everywhere. And I can't tell you how many vineyards are just dying on the vine where they weren't even picked. The wine sales are kind of collapsing and beer sales are too. It's the ready to drink cocktails. The young kids just love them, Chad. And so that has really kind of taken over, and wine sales are really down. And it's kind of a minor to major crisis here, at least for the growers, trying to figure out what to do in Lodi. So I really liked hearing the beginning of the show with you guys talking about obstructive sleep apnea, because I just got back from a course about a month and a half ago that in Houston, Texas, Chad. So you'll appreciate this. I got to achieve one of my dreams, which was
Buc-ee's.
going to a Buc-ee's. Oh my God. As a
It's
kid in
so
California,
amazing.
I've wanted to go to Buc-ee's for so long. I watched a lot of YouTube videos on people going to Buc-ee's and only eating there for 24 hours or trying everything on the menu. And it was life-changing. I have everything is Buc-ee's now. All the stuff I take fishing, the thing I take my food in, drink my water out of, my hats.
So this is not a one and done. This is not a one and done, Mike.
You will go back.
Well, I have a lecture in Colorado next month, and they just got their first Buc-ee's. So no, anytime I go somewhere, I check to see if there's a Buc-ee's or a Waffle House. Those are the two places that we just don't have in California.
Buc-ee's. And then I went, and then I was like, okay.
Really?
Been there, done that.
Why did you expect more than 120 gas pumps, or what were you? What did they shoot?
Yeah, and the beef jerky bar? No?
Yeah, the beef jerky bar. They're yelling every time there's fresh brisket on the table. I mean, it's. I
like name brand candy. Okay, I don't like my candy packets to be.
Yeah. Okay. Yeah. All right.
Then you probably don't like you probably don't like Trader Joe's either. Because they have all their own stuff and not. Oh, okay. Yeah, the beaver nuggets. Chad's right. Those are. I mean, come on. Yeah. Nobody can copy those or.
I don't even want to say beaver nuggets. Forget about.
I know. I know. I know it's kind of.
Let me just tell you. 6 miles from the house.
I wanted to share one other thing, Jeff, real quick from your story. Having a wallet and phone combo, I think, was a game changer. It has simplified my life so much, not having to carry a wallet. I can't wrap my head around the concept of a man purse and carrying a big wallet around. And so mine's a phone with a wallet on the back and an air tag on it. And mine has never been stolen, but I did drop it into the California Delta and watch it sink 15 feet. And I didn't know how I was going to get back into my house, or I had to get gas on the way home, and I couldn't use Apple Pay, and I didn't have any of my credit cards. And I was like, well, it is debilitating when you lose it, but when you have it with you, it's a game changer and just the greatest thing ever. So yeah, I feel your pain. I've lost it too.
I get it.
So I got to tell you, Mike, 6 miles from my house, not only do I have a Buc-ee's, but I have a NASCAR track that the Buc-ee's sets on. So, I mean, we got it going here.
Wow. You are living the redneck dream. That's amazing.
I am living the redneck dream.
Here's how I was diagnosed with obstructive sleep apnea. I went on a fishing trip, a week-long fishing trip. We were camping in tents, and I was alone in my tent. And the next morning, the couple next to me, the guy said, "Hey, you were snoring pretty loud last night." Like he was shaming me a little bit. I'm like, "Oh, I'm sorry, man. We had a couple glasses of wine or whatever." And his wife said, "It was more than that. You were gasping for air." I was like, "Seriously?" She's like, "Yeah." I'm like, "Oh God, I have sleep apnea. I should have known. My dad has it." So I came home and bought a home sleep test, took it home, saw that I had it, then went and saw a sleep physician here. And that's how I got into it. I was taking 3 naps a day at work, not like long ones, but like falling asleep, sitting at the chair. My life has just been turned around by getting involved with this and treating myself. And you can't feel this good about something and not start with patients. So I've got an oral appliance that I wear half the time, and I still use my CPAP half the time just because I want to be able to talk to patients about both of them and the differences between the two, and possibly encourage them to maybe think about combination therapy if their pressure is really high in their CPAP and they hate it, or maybe they go strictly to an oral appliance. But it's been a big deal for me. And just this last week, I got one card from a patient. She was mild OSA. She's a veterinarian in town, but she said every morning when she woke up, she felt like she'd been hit by a truck. And I thought that sounds like a lot for these kind of symptoms. We put her in an appliance, and within 6 weeks, she came in for her follow-up, and she brought me a card, and I said, "Oh, look at it later." I didn't know what it was, and I saw it later, and she like had written the word "thank you" in like 9 different languages on the left-hand side of the card, and then the card said, "There aren't enough words in the English language to thank you for your skill and expertise." I'm like, "Well, I've only been doing this 18 months, but okay." And then she said, "You've given me a new lease on life." And I'm like, "Holy shit!" Like you don't hear this after scaling and root plating or endo or even crown and bridge for the most part,
That's right.
or even veneers for that matter. And then another patient last week came in and brought a bottle of champagne, and she's so happy and feels great. And her husband and her are sleeping in the same room again. I mean, it's just, I wouldn't have done this had I not been diagnosed myself, but I'd like to encourage other dentists watching to, if you want to get cards and hugs from patients and bottles of champagne, I would seriously think about doing this. And I can just tell you from my own experience how much my life has improved, my energy has improved. I lost 35 pounds once my hormones fell back in line when I started sleeping through the night again. And it's amazing. I mean, whether it's my appliance or my CPAP, when I put those on, I have this very positive connection about I'm going to have a great night of sleep. I'm not going to hear the stupid train that goes through Lodi 3 times a night and blows the horn like I used to all night long. And it's been a life changer for me. And I'm super excited to hear that you guys, and it sounds like Jennifer's really into it as well. So I think it's great that dentists are doing this. And I just got back from hosting Thrive Live, Shine's big annual meeting. And we had Dr. Michael Bruce, who calls himself the sleep doctor. And he started off his talk, which was cleverly called How to Be Better in Bed, which I thought was cute. But he started off his talk thanking the dentists in the audience, saying, "You guys do so much more for patients in obstructive sleep apnea than pulmonologists. They always end up with pulmonologists or whoever." And he goes, "That's down here. That's the lungs. The obstruction's up here. So you guys are dentists are uniquely qualified to treat this." It was great to hear a physician really give us props for what we're able to do with this type of treatment, and the fact that we're trying to screen people. And one of my standard questions for every patient is, "How'd you sleep last night?" And nobody ever says, "Well, that's a weird question." A lot of them say like shit or not very well. And then we just get into a conversation and start talking about it. And I go, for $99, you can take our home sleep test home, and it'll tell us whether or not you have it. And then we'll at least know, and we can make a decision from there. And I want to make t-shirts for my staff that just say, "How did you sleep last night?" so that we don't forget to ask people about it. It's some of the most rewarding dentistry I've ever done. And again, I feel grateful that I was diagnosed with it, or I would have never dipped my toe into this. So it's good to hear that you guys are into it as well.
Since now that you have had this epiphany, we're in my world, heavy restorative. You knew restorative. Your current practice is very focused on that. How do you see the cases now? Do you feel like as a clinician, you see them differently? Are you setting them up differently? Or, from a restorative perspective, it's the same old? I think for me, it was an interesting evolution of expansion and widening and trying to get bigger arches and tongue space and all that. And had I not had the sleep training coupled along with, heavy restorative training, I don't know if I'd see it the same way.
Yeah, I don't know that the restorative training ever set me up for it. When I got out of school, I finally, for the first time in my life, went through traditional ortho, and I was so intrigued by it, watching my teeth move and watching how little work the actual orthodontist did, that I got very excited about wanting to do this in my own practice. I'm like, her assistant seemed to be able to do all this, and she just, I don't know, she was there the very first time, I guess, but it was a simple, straightforward case. So I took a bunch of classes and started doing traditional ortho back in the day. And first I started with just adults, and then started doing some kids. And it was the kids that really got me excited, using twin blocks and other functional appliances to help develop this. And for me, it was just developing it because I wanted to get that big, beautiful, broad arch for them so that we had room for all the teeth, because I knew nothing about sleep. So really, it's come back to me now that one of the main reasons I wanted to go back into practice wasn't OSA. That happened after I bought this practice. But I was seeing what people were doing with clear aligners these days. And 20 years ago, when I first did Invisalign, when I was still at Glidewell. We didn't have any attachments. It was really old, like generation one of the tray material. They had been around for about a year. And it was just so frustrating trying to move teeth that way compared to doing it with bands and brackets that I gave up on it. And then when I started thinking about buying a practice after COVID, when all the lecturing and consulting stopped, and I was not a very good consultant when somebody wanted to send me their new cement and I didn't have a practice to try it in. So I was like, I really should buy a practice and get back into this. And I had shoulder surgery and I really kind of fell in love with my orthopedic surgeon. I was like, you know what? I want to be that guy again. You know, I want to be the one where when people come in, I can be the one who offers help. And I was like, I forgot. I'd gotten away from that and I wanted to do that again. So I started to see some of the cases that dentists were doing with Invisalign. I was like, what? You can't do that with Invisalign. And the closer I looked, the more I realized you could. So when I originally got started doing Invisalign 3 years ago, it was just about straightening front teeth. And then I happened to see Stephen Schalk and Terry Coddington do a lecture and talking about airway and expanding arches. And that's when I changed the template that I was using for my ClinCheck so that we could move molars and not everything was just going to be, you know, straightening the anterior teeth. And we have taken a couple people. We have one guy, this 55-year-old guy who had this narrow V-shaped rat-like arch and totally developed it. His face looks different. He stopped growing his mustache because he's not trying to hide it anymore. This is a 55-year-old guy, and it was crazy what we've done with his arch. And so I love being able to give more room for the tongue and really develop these arches. So it wasn't so much about restorative for me. It was about using aligners to help develop these arches that should have been expanded and developed when they were younger, but it just was never thought about. It was like 4 bicuspid extractions and retract instead of like, let's try to develop these arches and make room for all 28 of these teeth. So it's been really with the aligners that I've gotten more into that. And we tell people, we don't tell them this is going to, you know, cure anything, but it is going to give more room for your tongue and improve your ability to breathe. But you might need, you know, one of these appliances as well, or possibly CPAP, but we'll test you for that too. So it's just opened my eyes looking at somebody and looking in their mouth, looking at their scalloped tongue, looking at the high vaulted arch and looking at all these things now and saying, hey, I tell them all the time, I say, a big part of my job is to look 20, 30 years down the road and help you make decisions that are going to make it so that, you know, you're not going to have to do anything like this. And we set you up well with a comfortable chewing system so that you're going to be fine and you'll be able to sleep and all this stuff. And so I like that line a lot about part of my job is to look 20, 30 years down the road, because they say nothing's bothering me now. I'm like, I know, but these things get worse. Your tissue gets flabbier, your airway's going to collapse more. And so I really like that. And then Smile Architect came out, and that was, I feel like that's what I've been waiting my whole career for, is to have a piece of software like Smile Architect.
Yeah.
Well, let's see.
So I got a question for you
about restorative. I'm sorry, Chad. You want to go?
No, Jeff, you go right ahead.
Why, thank you, Chad. So no, it's funny because I kind of came into ortho at a very early point in my career. When I moved to my hometown, only one orthodontist in the entire county, only one pediatric dentist. So that's really what started me down an ortho track and learning about pediatrics and pediatric airway and growing and all that. But what's incredible about all that is, yes, I was shaping airways. I was always thinking about airways. But even more importantly, it changed the way I thought about restorative dentistry. It's not, what do I do with what you came in with? It's, what kind of a template can we create to give you the ultimate restorative care? And by the way, we're going to make the next 30 years of your life better, as you said, by making you a better breather, by giving your tongue more room, and just really looking at the big picture. So it's amazing how, you know, airway, restorative, everything that we're talking about really can go back to some of the things that we can do orthopedically or orthodontically.
Totally agree. And yeah, and I feel like, you know, 20 years ago, I wasn't ready for this. I'm not sure patients were ready for it either. It kind of feels like I feel like I'm putting out way less fires in people's mouths in my practice, like rampant caries and things like that. It's a population who is into wellness. You know, I'm shocked how many of my patients know about obstructive sleep apnea or know somebody who has a CPAP, their brother, their uncle, or whoever. It's not the mystery that I thought it was. A lot of people have heard about it and are aware of it and are interested in finding out whether or not they have it and just taking this test home. And I know they'd be better. They would get less false negatives if they went and did it at a sleep lab, but it's so easy to be able to do this at home. And I heard you mention some of the wearables coming out. Even Pacific Sleep here in Lodi, one of the doctors who refers to us and the one doctor who I see is now sending patients home with wearables, even though he still does sleep studies. And he's like, yeah, he says the at-home studies miss 10 to 15% of the hypopneas. He said, I just kind of add those onto my head, but people really would rather do that. But we're so into it now that my hygienist just took her 6-year-old son in for a sleep study the other night. It's pretty clear to her and me that he's got breathing issues, and it looks like it's related to what's possibly ADHD for him and some behavioral issues and challenges that he's having in school. And I'm just waiting to see what happens as they develop his airway or whatever ends up happening in terms of his treatment, because this will be one of those stories that I'll share with tons of patients. And so I've only been treating adults. You mentioned pediatric airways, and it looks like having a hygienist with a son who's got these issues, who's got huge tonsils. And we keep hearing from ENTs that to get adenoids and tonsils out, you have to have 6 cases of tonsillitis in a given calendar year, which is freaking ridiculous. So hopefully we can find somebody to take those out and start to see what happens when he's able to get air all night, because he snores every night. And I can't imagine that a kid without allergies at the age of 6 should be snoring.
Yeah.
I was giving a presentation a couple weeks ago, and we were looking at CBCTs and airway constriction, minimal airway constriction on CBCTs. And this guy stops me, and it's in Texas. And in Texas, everything takes a long time to come out of the mouth. But he started talking about tonsils and started talking about how many infections they need to get per year to get their tonsils out. And then he goes, my daughter had her tonsils out, and she was having trouble breathing. And then she was watching a Cowboys game, and she started bleeding profusely, and we had to call 911. And I was like, okay. And so he started talking about an ablation. And at the end, I said, I usually bleed out the mouth when I'm watching the Cowboys as well. But I do understand that your daughter might be having problems. But are any of you all familiar with this tonsil and I'm, pardon my ignorance, but the tonsillar ablation procedure as opposed to having them completely removed?
Me. We had an otolaryngologist that was doing it here at Duke. And actually, I sent my adult patients to him. I didn't send pediatric for ablation, but I sent adults because the risk of surgery is much higher. So he was doing it with a cold laser. And we were getting phenomenal results with that. The postoperative discomfort was a couple ibuprofen for 2 days. They were back at work, minimal bleeding. They're not removing the entire tonsillar tissue, but they're peeling it back. The number one complaint that I was sending it for actually was for stones, because people were getting these chronic stones and they were motivated to want to get them out. And they could get medical coverage for removal of that. But he retired and no one has taken up the technology to continue to provide that service at Duke. So I saw it firsthand in my practice, what a benefit it was, particularly for adults with the risk of going under for tonsillectomies and adenoidectomies is much, much higher. And the postoperative issues that come along with that is much more complicated too.
Well, we talk so much about sleep, and I love this conversation. And, I think that every patient is unique. Every patient's, got some, different comorbidities that present. But, tonsillectomy is not for everybody. And it is a hell of a painful procedure to do later in life. And so I'd love to learn more about this. I think we need to get an ENT on to talk about this, or, somebody that has experience with the ablations to talk a little bit more about it, because that may be something as well. Not necessarily. I think orthodontic therapy and what you guys are doing is fantastic, but I think it's something that we need to discuss further. So that's my 2 cents.
And let's be honest, Chad, as a lifelong Cowboys fan, you bleed from more than one orifice.
Yeah,
it's been a rough
You
go
really
recently. They do not treat you well.
No.
My 2 teams are the
owner
same.
leaves.
So there you go.
Yeah.
So
I feel like
you
guys are just sticking around now for snacks and cheerleaders. Like it's really not football anymore. It's not.
Yes.
Jennifer, I heard you chime in when I said that Smile Architect was the software I've been waiting my whole career for. And I feel like every time I use Smile Architect, I feel like it's one more tick in the column of me not going to hell or dental hell. Anyway, because I look back at my LVI days after going through LVI in 1994. And the way we used to prep veneers back then, where we didn't care where the teeth were. Some of the teeth we didn't prep at all because they were so far lingual, we would just put a 4mm thick veneer on it. And then other ones that were, out to the facial, we just prepped the crap out of them. And Dickerson and Hornbrook both loved prepping into deep pink dentin, and they both loved etching the pulp for some reason. I don't know why. It's a weird fetish to have. Of all the fetishes you can have, etching the pulp is a strange one. But I tell patients all the time that about veneers and being able to turn patients from prep veneer cases into no prep cases. And the way we do it is, I actually share my cases through the treatment planning through TPS. My lab is actually one of the labs that's on the TPS. So when I'm doing a Smile Architect case, I send it down to my technician, Cindy, and she will often just, as she looks at the ClinCheck too, before I send it in to get the aligners, and we'll tilt the maxillary anterior teeth back a couple degrees to basically make room for the 0.3 millimeter no prep Emax veneers that we're going to bond onto the teeth so they don't look like Buc-ee beavers, like a lot of no prep veneers used to look back in the day. And so so every patient's always wanted no prep veneers. DenMat knew it. They were advertising on the back cover of People magazine and Cosmo, but they just didn't look good. You always had to take away some enamel to replace it with lithium disilicate or whatever to make it look good. And those days have really changed. So I'm so into being conservative now, and any patients who's willing to give me 4 months, and just about anybody, we can move the teeth enough in 4 months to get their maxillary 10 anterior teeth into an almost perfect, and you don't have to get it perfect. The hard part of Invisalign cases is that last 10% detailing and getting it perfect. Well, now your laboratory technician does that for you. And so being able to tell a patient, if you will do this, if you'll wear these aligners for 4 to 6 months, we won't have to take a drill to your teeth or do any drilling. And I love it because when I used to do these deep veneer preps, which were frankly 3/4 crown preps for the most part, we'd prep everything but like the cingulum. There was a lot of postoperative sensitivity and a lot of teeth that ended up needing endo. And it's not that no preps are simple. Seating no preps, I think, is actually harder than seating prep veneers or crowns because of the way they tend to float around. So that really takes some detailing and thinking through it to make sure that ends up correctly. But it's amazing when you look at a veneer case that's, let's say, $10,000, and then you add another $4,000 or $5,000 on for the Invisalign. And for that price, we won't touch a drill to your teeth. A lot of patients want that upgrade. For $4,000, I don't have to touch a drill to your teeth, and they're going to look perfect, and we're going to be bonding to enamel. They're not going to come off. We don't have to worry about recurrent decay. It's kind of a dream come true. We don't have to temporize it. There's so many nice things about this, and the ability to do this at the time of the ClinCheck to me is revolutionary. And I am so thrilled that Align, had this vision to do it. And now I'm getting to lecture next month at my first CDI program, comprehensive dentistry with Invisalign. And I think it's just amazing what you can do. And I really think if you're going to call yourself a great restorative dentist, you have to be able to move teeth. Now, that was a tall bar in the past because you had to learn how to do brackets and arch wire, and no adults really wanted it. But now it's much simple and straightforward, and something that patients are very willing to do. And 4 months is not a long period of time. And we take some cases that are we just finished a case that is so amazing to me. It was a guy that he had his primary cuspids, 6 and 11 were behind or lingual to 8 and 9. It was the craziest thing I've ever seen. He looked like a cobra. And so we had to figure out what to do. And we couldn't move 6 and 11 to their original position. It was just too far. It wasn't going to happen. And so we ended up having an oral surgeon take out 6 and 11, take out the baby teeth. And then we started his Invisalign treatment. And he had a really gummy smile that he didn't like either. So a typical ClinCheck will line up the incisal edges and make them look good, because that's typically what we do in orthodontics. And what I did in Smile Architect with 3D controls was go and line up all the gingival levels to a point. So we're intruding some teeth. He's 27 years old, so intrusion is going to work a lot better on him than a 57-year-old patient. We intrude his teeth to get rid of his gummy smile, because otherwise we're going to have to do hard tissue crown lengthening. So line up all the gingiva. Now his teeth look all funky, but they're only going to look funky during that 4-month period. And when we finish, and as soon as we're done, we can do the veneers. And that's where we make up those incisal edge length discrepancies. So we got rid of his gummy smile. he got 2 implants and we put crowns on those teeth, and he had veneers on 7 through 10. And it's just amazing because he had a gummy smile. He's 27. His gummy smile made him look like he was 14 years old. And now he looks like the handsome 27-year-old guy that he is because that gummy smile's gone. It's crazy how gummy smiles really give people insecurities about looking like a kid. Plus, he had 2 baby teeth when he came in, so he really looked like a kid. And it's just one of the amazing things you can do with Smile Architect, because that case before, I wouldn't have known what to do. I just would have prepped those teeth for veneers, and he still would have had the gummy smile. And or he would have had to have hard tissue crown lengthening and a surgical procedure. But instead of a surgical, well, he did, to have his 6 and 11 removed and have the implants placed, but no surgical procedure beyond that. And we were able to just turn this smile into something wonderful. And that would have been really difficult to do without Smile Architect for a GP like myself, who's not super into like high-end digital smile design. Just to be able to do it like this, and it's a free software that's available to you, is amazing to me. And I think to be a great restorative dentist today, you have to be willing to learn how to move teeth and then actually move teeth prior to restoring them, to give yourself the most conservative and aesthetic results.
Well, don't you think too, like when you pop those up and you can show them, here's just moving teeth, here's moving teeth with restorative, pros and cons. You're also, as a clinician, already managing your own liabilities. You're like,
right,
oh, if we don't do this, then these are going to be the issues that we run into, or the compromises. Those conversations with patients are so impactful because the expectations can be, to your point, I'm not a huge cosmetic dentist. I like to do nice cosmetic cases, restoratively driven, but moving teeth. But I love to mitigate all that from the get-go. I don't want to hear at the end of the cosmetic case, oh, that gum tissue looks a little bit asymmetrical. Well, let's have that conversation. And with the free software Smile Architect, I can have that conversation and pop it up in front of them. And we work out all of that, those nuances before we touch anything, which I love the visualization of that.
Yeah, and it's so funny. I'll sit down with the patient so for dentists who haven't seen it, it actually shows, one pane shows the patients before, where they are now. One shows, here's what you look like with just Invisalign, which may be great, or it may be now you have straight kind of ugly teeth. And here's what you would look like with Invisalign and restorative. So maybe it's veneers on 4 through 13 or 7 through 10. And then you can talk to them about it. And then I'll point at, maybe there's a gummy smile on 7 and 10. I go, does it bother you at all how that gum shows there? Or is that not a big deal? And a lot of patients will go, oh my God, yes. No one's ever mentioned that, but you're right. I hate that. Well, let's just move those teeth up. And I'll use 3D controls right in front of them, which blows them away too. In fact, I just started a patient last week who somehow an orthodontist did brackets and arch wires on her and then finished her with Invisalign. And she didn't like where she ended up. And the orthodontist was like, there's really nothing else we can do. I was like, oh, I wish I need to learn how to say that to patients. That is so
I'm sorry, we're
crazy
done here.
No, that's right. That's right. I'm a specialist. Don't question it. And
it doesn't end well.
Yeah, she's like, I want these black triangles. She didn't say black triangles, but I want these spaces gone. I'm like, did they do any polishing in between your teeth? No. I'm like, well, let me show you what we can do, with some I didn't say IPR, but here's what we can do, some IPR. And I'm showing her, I'm putting the IPR and moving the 2 teeth together on the screen. She's like, oh my God, we can do that? I'm like, yeah. And it was 1 millimeter of IPR. It was going to take more than the 0.5. It was going to take 1 millimeter, but she's so excited about that. She doesn't even care. And when she saw that we could do that, she's like, that's amazing. So where my teeth are going to end up? I said, if you wear them 22 hours a day, and if they don't get all the way there, we can do a refinement. So sometimes, Jennifer, they'll ask me, do I have to decide on the veneers now if it's a Smile Architect case? I said, no, you don't. But we're going to move your teeth, but we are going to put them in a little different position if you decide you want the veneer. So here's what we'll do. We'll move the teeth for the 4 or 5 months, or whatever it's going to take. There's a lot of 6-month cases these days. If they have a good arch form and we're not having to expand, a lot of 6-month cases with the new material and these ClinChecks. And so we're able to show them, okay, let's do it when we get to the 4, 5, 6 month point, however many aligners it might be. If you decide then you want to do the veneers, we'll do a refinement for probably about another week, just to kind of tip those teeth back. And then we can scan for the veneers. And so I like to finish all my cases with 1.5 millimeters of overjet. And the first template I was using did not do that. We ended with very tight anterior coupling, and I was seeing interferences and posterior open bites, and then people relapsing just because their teeth were hitting again. And so if you ask Align for during the ClinCheck process, if you ask them for 1 millimeter of overjet, for some weird reason, they measure it from the facial surface of
I
the
don't
maxillary anterior tooth to the
understand.
facial. I know. So you have to say the key term is interincisal clearance. You have to say,
Yeah.
please have case finish with 1.5 millimeters of interincisal clearance. 1.5, we may not get there. I'm fine with a millimeter. I just don't want those anterior teeth touching at all. So if we finish there, we have room to tip them back.
Yeah, I think you have just brought up one of the most important points with regard to preparing for good restorative dentistry. I think where so many dentists get into trouble with aesthetic dentistry is not taking care of that interocclusal clearance anteriorly, constricting the envelope of function. We see it all the time. And the having the ability to allow for some extra space there to build your restorative material and not interfere with that envelope of function is just huge. I'll make one other point too, which really quickly, Chad, JB, I think we need to put together a program on bonding of no prep veneers, because dentists are very good when they have, you know, an absolute index to sit on, like a preparation. But just as you said, Mike, when we are able to do these no prep veneers, which I think are a godsend, and being able to prepare for them orthodontically first. But I think that there may be some confusion about the best way to seat these and not have errors in seating when you don't have those true indices that you're used to having, you know, when you bond a prepared veneer, or a prepared tooth, I should say.
Yeah. Yeah. And so anybody who's done no prep veneers, you know what it's like. You play whack-a-mole. You put 8 and 9 in and it's fine. Then you put 7 and 10 in and 8 pops up, and you push 8 back down and 7 moves. You put 6 in and 7 pops up. And it's fine with the try and paste where you're just getting them all in so the patient can look with the mirror and they go, oh, that, yeah, it looks great. Let's do it. All right. You take them all off, clean them all up. And then I used to etch everything and prepare all the veneers and then etch it all at one time. And I don't do that anymore, because now that I'm doing really nothing but no prep veneers, I've had to refine that technique. So once we've tried them all in and the patient likes it, we clean them all up. I put 8 and 9 back in just by themselves and make sure they're good. Great, take it out, etch 8 and 9. As my assistant prepares 8 and 9 to put them in, we put 8 and 9 in together. That's never a problem, usually 8 and 9 going in together. Mm-hmm. And they can't go too far mesially, but they can always slide a little bit distally. And usually you learn this when you get to the first and second bicuspids, and they won't go down at all. So we put 8 and 9 back in again, and we those are in, and we take our 2 millimeter curing tip in the middle, spot cure it, clean up around the edges, final cure 8 and 9. And then you have to take 10 and 11 and try them back in again, even though you've already tried them in, now that 8 and 9 are in their final position. Yeah. So you try in 10 and 11 again, because you might have to adjust contacts, maybe not. And now you etch 10 and 11 after you adjust anything that might need to be adjusted and place those in, and then try 7 and 10 back in again now that these are all there, and then try the bottom. So it's slow. You're going slower. You're not preparing the veneers because you're trying them back in the mouth. You're not etching everything at the same time because you might use try-and cement or just water to try them back in. So you just have to go slower. And don't get frustrated about that. Look at all the time you save by not prepping and temporizing these. 100%. Go ahead and take your time on this and make sure you're putting them in, because it's super frustrating. I have a patient now where I'm going to have to take off number 8 because I got a little ahead of myself, and I took it off and I resat it during the live cement. So I put 8 and 9 in, and I started curing 9 and cleaning. I didn't like 8. I took it off. I adjusted. I put it back in. And I think I trapped air between the veneer and the cement by just putting it back on again. And because the tooth looks just a different shade than all the other 9 veneers that are in there. So she's coming in next week to cut it off. And I think it was I think I probably should put more veneer cement inside that again and pushed it down. Always want to have too much Variolink aesthetic coming out. You know, I think it's only problems when you don't use enough of it. I know it's expensive, but because there's nowhere for them to seat. And so seating these 10 veneers should take 3 to 4 times as long as if you were seating 10 crowns. But you can't get frustrated about that. Look at all the benefits. We're bonding to enamel, the strongest bond in dentistry. We're not going to have postoperative sensitivity. We're not worried about recurrent decay on some dentin. And you didn't have to prep and temporize it. So treat this as the important appointment that it is, and slow down a little bit and try things in multiple times as you work your way through that to make sure you don't get kind of stuck like I did on that one case.
Great message.
I have also found too with Smile Architect that there are many cases that come in for restorative. We move teeth, give them a tube of whitening, and they're happy as a clam. And, you know, and we're ready. We're set up. We set it up in Smile Architect, ready to prep teeth or, you know, do whatever restoratively we had planned. But really it was just tooth position and light reflectivity and decoupling and all level and aligning and all that stuff that then they're like, you know what? I'm actually perfectly content. I have this case in particular. This lady had 2 central veneers on and veneer, like 3/4 crowns. And I hate taking off people's works. You have no idea what's sitting up underneath it. And the dentistry actually looked really good. The color was a little wild. Like there was just some things about it that looked a little off, but just a little bit of, she was fully prepared to replace crowns and do some veneering, but just a little aligning in Smile Architect and pre-planning that and then giving her a tube of bleach. Those puppies are still sitting on there. And I'm actually perfectly fine with that because, you know, they were clinically sound veneers that were servicing her well. And as a dentist, I'm very humble to say, like, can I do better than the previous doctor that came in here? And I have no idea what I'm opening up when I get in there and, you know, all of the things. So conservative for me is for a win every day.
I want to ask you guys something and get your quick feedback on it. I know we're almost done, but one of the things that there was something that I ignored for all 37 years that I've been in practice because I didn't know what to do about it. I didn't know what caused it. No, it's not black hairy tongue. It's abfraction lesions. And I was taught in dental school, patients are brushing too hard or using too abrasive of a toothpaste, which seemed weird that they could do that on a second bicuspid, but not the first bicuspid or the molar right behind it. Didn't make a lot of sense. Tried to figure out why it only happened on the buccal and never really happens on the lingual, although I did see some lingual ones the other day. And every time I put a composite in, it would pop back out. Anytime it was sensitive, and a composite would pop out. Then I'd put some retention grooves in it for the composite, and now it'd be sensitive for the next couple of years. It was just such a I would just pretend they weren't there. If a patient said, "What's this notch?" I go, "Where?" They go, "Right here." I don't see it. I would just ignore it. And then I started learning. Looks fine to me. We all have those. Attending.
I am not
Invisalign
listening. I am not listening.
Talking about lingually tipped dentition, you know, hitting on lingually tipped dentition and how it's flexing the teeth and uprighting those teeth to where they should be in the arch and going, wow, this is amazing. And so once I realized that there was a way to put the teeth in the correct non-traumatic position so that they wouldn't get any new abfraction lesions and wouldn't pop out restorations that we put in the other ones, I decided to get serious about this. So my staff and I wrote an Abfraction manifesto and made I didn't make everybody sign it. I had them sign it if they believed in what I said. And that is that abfractions are pathological, not normal. And we need to tell patients about them. So now if a patient comes in, we scan every new patient with our Lumina, of course. Well, we have a Lumina and a 5D Plus that we're about to upgrade to the Lumina because I thought the 5D Plus was the greatest until I got the Lumina. Now I realize the 5D Plus is a piece of crap. The images look nuts. I was like, oh my God, I need all Luminas here. And nobody wants to use it. Everybody's fighting over the Lumina and not wanting to use the old 5D Plus. And we scan everybody who's not getting x-rays at their recall appointment as well, do a wellness scan. But now if somebody comes in, even if they're due for x-rays, and especially if it's somebody who hasn't had a carious lesion in 5 to 7 years, I know Delta Dental will pay for another set of bite wings on them. But instead, let's do a scan if they haven't had one and talk to them about their abfraction lesions and putting their teeth in the correct position to keep this from happening anymore, especially if we're lucky enough that they have some thermal sensitivity on 1 or 2 of them, so they know it's a problem. And so we have now, I would say most of the Invisalign we do, 80% of the Invisalign we do is either pre-restorative or for something functional like abfraction lesions or traumatic occlusion. And only 20% is for aesthetic reasons, for crowded lower anteriors, I would say. What are you guys doing, I'm wondering, for abfraction lesions in your practice? Have you kind of solved this conundrum in any way, or I'm just interested to hear?
I'm like you. I recommend orthodontic therapy.
Okay.
I mean, it's pathologic and it's due to traumatic occlusion, and it's not like brushing a bar of soap. And it's something that they need to at least understand.
JB?
Yeah, my practice split actually sounds very similar. Most of the Invisalign I do is functional or for pre-restorative, or any type of pre-prosthetic. And it's a very impactful conversation, especially if they start to have issues with those abfractions. Then we're starting to really open up the opportunity for that conversation if they're slightly sensitive. I've even seen benefit with recession. I have a great case of that where it was going to become an abfracted lesion, but a lot of that was frictional force on the tooth, and helping patients understand whether it's a bony pathology or it's a frictional pathology. And so, moving teeth doesn't solve all recession, but putting teeth in that right vertical position under load actually can protect a lot of the periodontium around it as well. So huge win for patients when we can set them up functionally that way. So our practices look very similar, I think.
Okay.
Yeah. And real quick for me, and then we've actually gone over, but I could talk about this for days. I'm into function. I'm all about function. That's how abfraction lesions start, is from poor function. That is why they will always be a problem if you don't improve function. Of course, we still look at them now as these non-carious cervical lesions. So once the lesion is there, it's only going to get worse, and it may get worse from toothbrush abrasion or erosion, or from toothpaste abrasivity. There are multiple factors that'll make it worse. But if you don't take that functional force out of there, the thing that caused it in the first place, you've missed the boat entirely. So I think we all are kind of in agreement on that. So I think you made some really great points tonight, Mike, and we appreciate you being on.
And there's nothing worse than doing a crown prep on a tooth with a major abfraction lesion, where you're going to have a 13 millimeter crown now that has to cover the mesiobuccal and distal buccal roots.
Or they had the abfraction all along. You opt for that super gingival margin, and then they come in and they're like,
it's sensitive now. Yeah, because you prepped it.
This is ugly. You didn't finish the crown. It doesn't go to the gum. And I'm like, damn it.
Oh, no, you need a veneer in addition to the crown. And insurance won't pay for that. They only pay for one restoration.
Yeah, that's where I go with yeah, I'm sorry. That's where I go with the gold foil, though.
There you go. Somebody's still doing it. I looked for gold foil in the Shine catalog the other day. I couldn't find it. I'm like, what? Do you not sell this anymore? You still sell green stick?
You're not doing class 5 gold foils?
The longest lasting restoration we've ever had in dentistry. Well, this is my second time on, you guys. I want to thank you for having me on again. What guests have you had on the most? Who holds the record?
You.
Oh,
that's a good question. I think
it's somebody. Viola, probably.
I think it's Tom Viola.
Okay.
Ryan Walsh.
Soto's been on a couple times, actually, 3 or 4.
Yeah, Carlos Soto, Ryan Walsh, the endodontist. But he's just kind of an ace in the hole.
Yeah.
But
speaking about the most mysterious subject,
we only have good guests on a couple times. That should make you feel better. So
good, thank you. I do feel great.
Thank you. We got the 7 timers jacket like SNL.
Yeah, exactly. That's what I was thinking of. I want to be able to try on that the 5-time jacket.
You want to be Alec Baldwin or
I'll accept my jacket. I'll accept it when I come out to Texas to Fish Lake Fork with Chad.
Perfect.
We'll put it on like the master ceremony, and then we'll go fishing in it.
Yes.
We're going fishing with Johnny Glass, baby. Johnny Glass.
That's right. Johnny Glass. Yeah. What a great name.
So, hey, I'll close this out. This phrase comes from Dr. Jeff Horowitz, but I think it just hits on everything we talked about tonight. And the phrase is, don't be so quick to pick up the handpiece. And, Jeff always says that, and it's not necessarily in the context that he says it based upon what we were talking about tonight. But I think that all of our cosmetic patients, we need to look at them and see how they could benefit from orthodontic versus restorative, or a combination of orthodontic and restorative. Not everything's going to turn into ortho. Not everything's going to turn into resto. They may be one or the other, but Smile Architect allows us to do orthodontically driven restorative care. And I think it's wonderful to be able to do. I want to thank Align. I didn't mention that Align was our sponsor for tonight, but Align has just been such a great educational partner of the show. I want to thank them for everything that they've done. I know that we all have a lot to thank them for in our individual practices. And Mike, I hope you go out and you catch a big ass bass.
Thank you. Me as well.
All right, everybody.
Good night, everybody.
Good night, everybody.
Have a good
Thank
one.
you.
Take care, everyone.